Morning everyone. In this class we are going to see about malignant disorders affecting the bones and joints, and this is the general classification about the disease of bone, which includes developmental disease, endocrinal disease, idiopathic disease, reactive, fibro-osseous, neoplastic and inflammatory. In the previous classes we have completed all these lesions, the developmental, reactive, fibro-osseous, benign diseases affecting the bone. So in this class we are going to see about the malignant disorders affecting the bone. First lesion is osteosarcoma. As the name indicates, it is a sarcoma developing from the bone, osteosarcoma. So it is a malignancy of mesenchymal cells that have the ability to produce osteoid or immature bone. It is a common type of malignancy to originate within the bone. Mostly it originates from the intramedullary region, not from the periosteal region. It usually originates in the intramedullary region. Clinical feature, it has extragnathic osteosarcoma has a bimodal age distribution. One is from 10 to 20 years and the other is at the later adult age. Usually the extragnathic osteosarcomas are usually seen in the distal femoral and proximal tibial metaphysis. Jaw osteosarcomas are usually uncommon. Both the maxilla and mandible are involved if it arises. The mean age is 33 years for the gnathic osteosarcoma. In the mandibular region, posterior border and horizontal ramus are affected. So this picture represents the pathogenesis of osteosarcoma, where because of germline mutation or sporadic mutation, the mesenchymal stem cells, pre-osteoblastic cell and mature osteoblastic cells are mutated and they turn into a osteosarcoma progenitor cells, which produces excessive which forms the osteosarcoma. The jaw osteosarcoma, if it arises in the maxilla, it arises in the inferior portion of the alveolar ridge, palate and sinus floor. Symptoms, if it arises in the maxilla, are swelling, pain, loosening of tooth, paresthesia, nasal obstruction, and it has a slow growth. So this is where the region, this is one of the clinical case reports showing the osteosarcoma arising in the maxillary posterior region. These are general signs and symptoms of osteosarcoma. Usually the subjects will have joint pain, swelling near the joints, loss of appetite, bone injury, loss of weight, masses felt throughout the skin, fatigue, difficulty in lifting the weight, frequent fractures, restricted movement of the joints. So this is another case report presenting osteosarcoma in the mandibular posteriors, where you can see as well ulceroproliferative swelling, and the radiograph of the subject showing large radiolucency involving the or affecting the mandible. Radiographic feature, it varies from dense sclerosis to mixed sclerotic and to an entire radiolucent lesion. Borders are usually ill-defined. There will be resorption of the teeth involved, which shows spiking root resorption. There is also osteophytic bone production on the surface of the lesion, which makes it to appear like a classic sunburst or sun ray appearance. So usually there is increased formation as well as there will be a radiolucent lesion and the borders are ill-defined. If it involves the tooth and alveolus, there will be resorption of the roots. And sunray or sunburst appearance is due to the cumulus cloud densities from within intramedullary and soft tissue, causing the mineralizing tumor osteoid. There is if it involves a long bone, there will be a triangular elevation in the periosteum in a tent-like fashion, which we call it as Codman's triangle. The other sign, radiographic sign, is Carrington sign, which is nothing but the symmetrical widening of the PDL space, which causes the widening of the lamina dura around the tooth, which we call it as Carrington sign. So the radiographic features of osteosarcomas are, it has sunray or sunburst appearance, Codman's triangle in the long bones, and Carrington sign, which is nothing but the symmetrical widening or thickening of PDL around the tooth. So these are the three characteristic radiographic features of osteosarcoma. So this is a picture showing the osteophytic production and which causes the sunray or sunburst appearance. Here also you can notice there is sunray or sunburst appearance, and the here arrow indicates there is a radiolucent lesion. And this picture shows the elevation of the periosteum, which we call it as Codman's triangle. Here also you can see the picture. And here there is an excessive bone formation in a ray-like pattern, which we call it as sun ray or sunburst appearance. So this is another radiographic picture where you can see mixed sclerotic lesion, and there is a osteophytic bone production, like 45-degree angle to the tumor mass, which we call it as sun ray or sunburst appearance, involving the posterior mandible and ramus of the mandible. The histopathology of osteosarcoma is that the malignant cells produce osteoid, chondroid, and fibrous connective tissue material. So, accordingly, they are classified into three histological forms: osteoblastic osteosarcoma, chondroblastic osteosarcoma, and fibroblastic osteosarcoma. The tumor cells, that is, the osteosarcoma forming cells, that is, osteoblast, which is a mutated osteoblast, it appears to be uniform round or spindle-shaped cells with highly it can be highly pleomorphic cell with bizarre nuclear and cytoplasmic shape. So this is one of the histopathological pictures showing a bizarre shaped cell, where you can see the pleomorphic nucleus. It is like appears to be like round two spindle shaped cells, and there are mitotic figures here in the picture. And these are the osteoblastic osteosarcoma. So this is another pictorial representation of osteosarcoma, where you can see tumor cells with varied morphology, with highly pleomorphic and hyperchromatic nuclei. There are also eosinophilic homogeneous glassy appearance lace-like material, which we call it as osteoid, formed by these tumor cells. And apart from that, you can see giant cells, areas of necrosis, and atypical mitotic figures also you can see within the cells. These are the various types of osteosarcoma. We call it as central osteosarcoma, telangiectatic central osteosarcoma, or surface osteosarcoma. Central, that is those tumors within arising within the medullary region, we call it as central osteosarcoma, and it has subtypes. The central osteosarcoma subtypes includes conventional osteosarcoma, telangiectatic osteosarcoma, intraosseous well differentiated, small cell osteosarcoma, low grade central osteosarcoma, high grade central osteosarcoma, secondary osteosarcoma. So these are the subtypes of central osteosarcoma. Subtypes of surface osteosarcoma includes parosteal, periosteal, and high grade surface osteosarcoma. This is the staging of osteosarcoma, where we stage the tumor based on histopathology as stage 1 low grade lesion, stage 2 high grade lesion, stage 3 metastatic disease. There are substages like if it arises within the intramedullary region, we call it as substage A, that is an intramedullary lesion. B, local extramedullary spread. So the prognosis is based on the prognosis also given based on the site of primary tumor. If the tumor arises in the distal extremities, that is in the femur tibia, it has best prognosis. If it arises in the distal femur, it has intermediate prognosis. If it arises in the axial skeleton, it has worst prognosis. Treatment for the jaw osteosarcoma or complete surgical removal. For extragnathic lesion, we should give chemotherapy followed by radical surgical excision and adjuvant chemotherapy. Metastases are usually common in extragnathic lesion if the tumor arises in the long bones. So this is about the osteosarcoma. And next, this is a subtype of osteosarcoma, which we call it as peripheral osteosarcoma. These are the tumors arising in the surface of the bone. So it arises adjacent to the cortex. It is classified as parosteal osteosarcoma or periosteal osteosarcoma. Parosteal type usually arises as a lobulated nodule with no elevation of the periosteum, which is treated by surgical excision. Periosteal type usually arises as a sessile mass within the cortex and that elevates the overlying periosteum. It perforates the surrounding soft tissue, and the treatment for this type of osteosarcoma is radical surgical excision with margins. There is other form of osteosarcoma, which we call it as post-irradiation bone sarcoma. This is not osteosarcoma, it is sarcoma arising in the treated area of osteosarcoma, where the sarcoma arising in a bone that was previously subjected to radiation therapy. So this type of sarcoma usually develops 3 years after radiation. The next malignant tumor arising in the bone is chondrosarcoma. Chondrosarcoma is a malignant tumor characterized by formation of cartilage from the tumor cells. It is the second most common tumor after osteosarcoma. Osteosarcoma is the first most common. Chondrosarcoma is the second most common malignant lesion affecting the bone. The extraganthic chondrosarcoma usually arises between the age of 60 to 70 years, and the involved bones are usually ilium, femur, and humerus. In jaws, it mostly develops in the maxilla. Less commonly, it affects the body, ramus, nasal septum, and paranasal sinus. The peak prevalence in jaw bones, the mean age of 60 years. The symptoms include a painless mass of swelling arise in the region with the loosening of the tooth, and maxillary tumors usually causes nasal obstruction, congestion, and epistaxis. Radiographical features of chondrosarcoma is it produces a radiolucent process with poorly defined borders. At times, there can be radio-opaque foci, which can be caused by ossification of the cartilages. There can be penetration. The tumor might penetrate the cortex, which produces sunburst pattern. There will be extensive infiltration between the osseous trabeculae of pre-existing without causing appreciable resorption. The tooth involved by the tumor can undergo root resorption, and there will be widening of the PDL. The growth usually shows a lobular pattern, and the characteristic radiographic feature of chondrosarcoma is it has a multilobular radiolucency. The histopathology of chondrosarcoma, it shows a lobular growth. Central areas of the lobule show a greater degree of maturation, and the peripheral area shows immature cartilage. So this is a histopathological picture where you can see a central area and a peripheral area. Usually the central area shows good calcification, and the peripheral area, it is not calcified as that of the central area, and you can see numerous chondrocytes here. So this is another picture showing the area of chondrosarcoma and the chondrocytes. These are atypical chondrocytes where you can see nuclear atypica. This is another form of chondrosarcoma, which we call it as mesenchymal chondrosarcoma, where there will be increase in number of mesenchymal cells, that is fibroblast is increased, and they tends to be pleomorphic, angulated to spindle shaped cells. So we grade the So the previous slide was about the grading of the chondrosarcoma. Grade 1, which mimics the chondroma, composed of chondroid matrix and chondroblast, subtle variation from the normal. Grade 2 is nothing but it shows a greater proportion of moderately sized nucleus and increased cellularity with more myxoid areas and less prominent hyaline matrix, and mitotic rate is also low. Grade 3, they show highly cellular spindle cell proliferation. Mitosis is prominent, cartilaginous matrix along with the bone. There are variants of chondrosarcoma, which includes like osteosarcoma, they had variants, right? Central and peripheral. So similar to that, chondrosarcoma has variants like clear cell chondrosarcoma, dedifferentiated chondrosarcoma, myxoid chondrosarcoma, and mesenchymal chondrosarcoma. The prognosis of this chondrosarcoma is related to size, location, and grade of the lesion. The treatment usually we follow is the surgical resection, and there are radiation and chemotherapy are less effective for this lesion, and metastasis is also low for this lesion. Local recurrence can lead to death by direct extension into vital structures of the kidney. So this is another variant of chondrosarcoma, which we call it as mesenchymal chondrosarcoma, and this is the more aggressive variant of chondrosarcoma. It is an uncommon and distinctive tumor of bone and soft tissue. It is seen usually in the age range of 20 to 30 years. It frequently involves the jaws. The symptoms are swelling and pain for short duration. Radiographic feature, it appears as a radiolucent lesion with infiltrative margins, and stippled calcification may be seen within the radiolucent areas. Histopathologically, we can see patternless mass of small undifferentiated spindle to round cells surrounding the discrete nodules of cartilage. The chondrite tissue usually show a well differentiated cells along with atypia. Treatment for this mesenchymal chondrosarcoma is surgical excision with wide margins. This is a picture showing mesenchymal chondrosarcoma where you can see this number of mesenchymal cells, that is fibroblast round tumor cells along with the areas of cartilage. So this is a cartilage formed region. It is surrounded by a numerous mesenchymal cells, round spindle shaped mesenchymal atypical cells. This is another picture representing the same where you can see cartilaginous areas with increased mesenchymal angulated or spindle shaped cells exhibiting atypia. The next tumor is Ewing sarcoma, which is a distinctive primary malignant tumor which is composed of small undifferentiated round cells of uncertain histogenesis. The peak prevalence of this tumor is they usually affects the children younger than 20 years of age. That is, subjects less than 20 years of age. They affect males and whites. Frequently affected areas are long pelvis and ribs. They are rare in jaw. If it involves, it usually affects the mandible. So this is a clinical picture showing the Ewing sarcoma in the mandibular region. Symptoms include pain associated with swelling, fever, leukocytosis, elevated ESR, which penetrates the cortex, resulting in soft tissue mass overlaying the affected area of the paresthesia, and loosening of the tooth can also occur. Radiographically, you can see a multilocular radiolucent lesion involving the mandible. So this is a CT, the 3D CT picture where you can see erosion of the caused by the tumors. Histopathologically, you can see small round cells which have a well delineated nuclear outline and ill-defined border. The tumor cells are arranged in broad sheets without any distinct patterns, separated by fibrovascular septa. There is large area of necrosis and hemorrhage. The cells contain glycogen granules in the cytoplasm, which is helpful in diagnosis. Cells are usually round, scanty cytoplasm and relatively large ovoid nuclei with dispersed chromatin and hyperchromasia. Cell borders are indistinct. The sarcoma cells are arranged in filigree pattern, which is a characteristic feature for this Ewing sarcoma. Many tiny vascular channels also present. There can be cellular pleomorphism and giant cell invasion are also seen. The tuberculous source usually resorption. So this is a histopathological picture where you can see round cells with distinct nuclear outline and nuclear atypia is noted in many cells here. Here also you can see the mitotic figures. This is another picture showing the Ewing sarcoma round cells which has a distinct nuclear outline and nuclear atypia, which are arranged in filigree pattern. So this is a filigree pattern. Treatment for this tumor is combined surgery, radiotherapy, and multi-drug chemotherapy. Prognosis is improved if the lesion involves the pelvic area. It has poor prognosis, and if the lesion involves the distal area, that is in the leg, it has better prognosis. Next type of tumor is metastatic tumors to the jawbone. They are most common form of cancer involving the bone. The primary site for this carcinoma that metastasis to the bone are breast, lung, thyroid, prostate, and kidney. The bones exhibit metastasis are vertebra, ribs, pelvis, and skull. Rarely, these tumors can occur in jaw. If it involves the jaw, most commonly mandible is affected. Usually, the metastatic spread of any carcinoma to the jawbone occurs by hematogenous route. It usually affects older age people between the range of 43 to 50 years. They most commonly involve mandibular molar region. They usually arise in a non-healing extraction socket from which tooth was removed due to local pain or mobility. Patient seems completely asymptomatic until the lesion is diagnosed by radiographic examination. The symptoms are usually pain, swelling, tooth mobility, trismus, paresthesia. If it involves a mental nerve, it causes paresthesia and the lower lip and chin, which we call it as numb chin syndrome. So this is a metastatic tumors involving the posterior mandibular region. Radiograph. The radiograph shows ill-defined or moth-eaten radiolucency, and metastatic prostate and breast carcinomas usually has radio-opaque or mixed radiolucent radio-opaque lesions. Some lesions mimic the periapical inflammatory disease, cortical erosion, pathological fracture, and widening of PDL space can also be noted. Bone scintigraphy is most sensitive for detection of this metastatic tumors. So this is a radiographic picture where you can see the bone is completely eroded in the mandible because of the metastatic tumor. This is another radiograph, which is an incidental finding where you can see a radiolucent lesion involving the posterior part of the mandible. Histopathology for this tumor is, in some tumors it exhibits well differentiated features. Most often they are poorly differentiated. You can see the islands of malignant cells filling the marrow spaces, and it resembles the histopathological feature of the primary tumor. Treatment. The solitary metastatic focus should be treated by excision or radiation therapy. Jaw metastasis always associate with wide, well disseminated disease. So management depends on tumor type and often is palliative in nature. Administration of bisphosphonates helps for slower progression of metastasis, decrease bone pain and reduce risk. Prognosis is poor. Most patients survive less than 5 years. The next or last type of malignant tumor involving the bone is Langerhans cell histiocytosis. Histiocytosis X, which is also known as histiocytosis X, which is characterized by proliferation of histiocytes-like cells that are accompanied by eosinophils, plasma cells, and multinucleated cells. Langerhans cells, which is a dendritic mononuclear cells found in the epidermis, mucosa, lymph nodes, and lymphocytes, which is an antigen-presenting cell. So this lesion is named after the medical student Paul Langerhans, the first scientist to describe the cell. The clinical feature is the lesion can be either monoostotic or polyostotic eosinophilic, like can exhibit as a monoostotic or polyostotic eosinophilic granuloma of the bone, which occurs as a solitary or multiple bone lesions without visceral involvement. The other form of this disease is chronic disseminated histiocytosis, where the lesion involves bone, viscera, and skin, which we call it as Hand-Schüller-Christian disease. The third variant is acute disseminated histiocytosis, where a disease occurs in the cutaneous, visceral, and bone marrow, which we call it as Letterer UV disease. They are usually seen under age 15 and it has male predilection. The bone lesion can be either solitary or multiple. Pain and tenderness is common. Radiographic features are it exhibits sharply punched out radiolucency with corticated rim. So this is multiple punched out lesions can be seen in this Langerhans cell type of histiocytosis. Histopathology. Soft tissue lesion usually occurs, it can also occur as a soft tissue lesion. If it occurs as a soft tissue lesion, it appears as ulcerative lesion, proliferative mucosal lesion, which involves the soft tissues. Histopathologically, you can see diffuse infiltration of large, pale staining mononuclear cell resembling histiocytes. Along with it, you can see eosinophils, plasma cells, lymphocytes, and multinucleated cells. Apart from these cells, we can see areas of necrosis and hemorrhage. The characteristic feature of the cells, there are presence of Birbeck granules within the eosinophils are seen. So you can see the tumor cells along with eosinophils, plasma cells, and the characteristic Birbeck granules are seen within this eosinophils. Treatment: curettage, low dose of radiation, single agent chemotherapy of prednisolone, vincristine, or cyclosporin. So this Langerhans cell histiocytosis are rare in adults, and the pathophysiology is incompletely understood. And the response to chemotherapy like vinblastine, etoposide, and steroids. And this is about the Langerhans cell histiocytosis. Thank you.